Middle cerebral artery. Technique. The circle of Willis is easily demonstrated by color Doppler ultrasound of the base of skull in the transverse fetal head position. In this plane, the middle cerebral artery runs in a vertical alignment along the edge of the sphenoid bone and are easily seen by color Doppler ultrasound. This figure shows circle of Willis on power Doppler. Identification of MCA. The fetal head is imaged in transverse plane at the pons. The pulsating MCA can be observed in the B mode image as it lies in a groove of the sphenoid. The MCA runs in a plane anterior-lateral to the midline, originating in circle of Willis. Reference ranges for Doppler studies. Between 18 and 22 weeks gestation, the normal uterine artery Doppler waveform will have no diastolic notches. Color flow localization of proximal MCA. Normal waveform at 28 weeks with minimal diastolic flow due to cerebral autoregulation. The upper MCA flowing towards the probe should be measured. Brain sparing effect in IUGR. In situation of low oxygen tension, the vascular tone is reduced in the middle cerebral artery, resulting in increased diastolic velocity and reduced pulsatility index values. This is known as cerebral blood flow redistribution of the fetal brain and is found in the more severe forms of early onset of IUGR. IUGR due to placental insufficiency is likely to be caused by redistribution of fetal blood flow in favor of fetal brain and stress organ at the expense of less essential organs such as subcutaneous tissues, kidneys, and liver. Low diastolic velocity. Low diastolic velocity indicates normal autoregulatory mechanisms limiting brain blood flow. The reference ranges for normal Doppler studies, the middle cerebral artery pulsatility index values are typically greater than 1.45 before term, falling to 1 by term. Ductus venosus waveform, its peak velocity is typically 55 centimeters per second with a small a wave. A wave less than 5 centimeters per second are abnormal. Intrauterine growth restriction. IUGR can be classified as early onset severe IUGR and late onset or mild IUGR. Early onset IUGR. This is the severe form of IUGR. Restricted fetal growth that results in either death of the fetus or delivery on maternal or fetal grounds before 32 weeks of gestation is with early onset IUGR. Typical ultrasound findings in early onset IUGR. The elevated head and abdomen circumference ratio indicates that small for gestational age fetus is asymmetrically growth restricted, sparing brain growth preferentially. The abnormal uterine and umbilical artery Doppler studies indicate uteroplacental vascular insufficiency. The cerebral blood flow redistribution to brain and reduced amniotic fluid volume are significant fetal adaptations to uteroplacental insufficiency. The fetus is at high risk for perinatal mortality and morbidity. Close fetal surveillance to advance gestation safely and planning the delivery properly by C-section will reduce these risks. Late onset or mild intrauterine growth restriction. Abnormal umbilical artery Doppler after 35 weeks should arise prompt consideration for causes such as aneuploidy, trisomies 18 and trisomy 21. Amniocentesis and FISH testing for chromosome assessment prior to delivery should be considered in such cases. Signs of late onset IUGR. Marked oligohydramnios, increased HCAC ratio, abnormal uterine artery Doppler, middle cerebral Doppler artery is 2 PI values, typical less than 1. Clue. Biophysical profile monitoring is superior to fetal Doppler monitoring in cases of late onset IUGR. Findings in case of healthy constitutionally small fetus, SGA. Normal HCAC ratio at 35 weeks. Following findings will be seen in symmetrically small but structurally normal fetus. Number 1, normal HCAC ratio. Number 2, normal MCA Doppler. Number 3, normal amniotic fluid. And number 4, normal grayscale appearance of placenta. Abnormal uterine artery Doppler. In late gestation, IUGR at 36 weeks. Low PI values in the umbilical artery. When pulsatility index will be low, the height of the wave would be reduced. Obvious redistribution in MCA, the peak of the wave will fall down, less than 5. This is abnormal placental morphology, that is calcific depositions in placenta and placental lakes, a lot of them. This will indicate abnormal placental morphology, that is a lot of deposition of calcium and everything. So what we learn from all this presentation is that deliver the toast out before it burns.